I'll start now.
Yes, Dr. Sandeep, you can start.
Okay, ma'am. So these are the values of compliance in the in different scenarios, as I told. Now, moving ahead, so this is again the pressure volume curve. Okay, this pressure volume curve, if the residents know, we see this very often in our day-to-day practice. Okay, I often ask you to have a look on the ventilator graphics when you are intubating and ventilating a child. So if the child is having RDS, what happens is, so the pressure volume curve will be flat and it will be towards the bottom. Okay, what does it indicate? That uh, here it is the pressure on the x-axis and the volume on the y-axis. So as you increase the pressure, the change in volume is not very significant. Okay, so this indicates that the lung compliance is very poor. You are increasing the pressure, but there is not much significant change in the volume. Okay, so that indicates a poor lung compliance, which happens in hyaline membrane disease or RDS. Whereas if you are into, as you change the pressure or as you increase the pressure, you can see that there is a significant change in volume. Okay, so even in an RDS lung, once you give surfactant over a period of time, the curve which was steep and flat initially, what you would see is eventually the curve will become erect and more towards the y-axis. Okay, so this indicates an improvement in the lung compliance. Okay. Now again, so as I told, see this pressure volume loop, pressure is on the x-axis, volume is on the y-axis. There are three different regions of this pressure volume loop. Okay. So one is the lower portion, which is a flat line. Then you have a middle portion, which is a straight line. Okay, which is an erect line. And again, you have a third or this third part, which is again a flat line or a straight line. Okay, so what does it indicate or what does it mean? That whenever you are intubating and ventilating a child, you should always try to deliver optimum PEEP and pressures so that you are ventilating the child in the zone of optimal compliance. Okay, if you are giving a too little pressure, what happens is most of the alveoli will still be atelectatic. Okay, so if my child, so this is what we call proportionality of ventilation. Okay, so if you are intubating a child who is having RDS और आपने उसको pressures दिए हैं 10/4 with an FiO2 of 100%, he will maintain saturation. But you have to understand that you are not giving proper ventilation. Why? Because you are not giving proper pressures. Most of his alveoli, they will still be under expanded, or this is the zone of atelectasis. Okay, so most of your lung will be in a zone of atelectasis because you are giving a pressure of 10/4, which is a very little pressure, but you are keeping an FiO2 which is very high. Okay, on the other hand, if you are ventilating that same child with a pressure of say 22, 24 with a PWP of 7 or 8, you are again ventilating the child in the zone of overexpansion. Okay, so what is the problem in ventilating in these two areas is, if you can see or if you can make out, as you increase the pressure in the zone of under expansion or over expansion, as you increase the pressure, there is no change in the volume. Okay, so ultimately the whole purpose of intubating and ventilating the child is defeated if you are ventilating in either the zone of under expansion or in the zone of over expansion. What we want is you have to intubate and ventilate in this zone of optimal compliance, where with a little bit change in pressure, you are able to achieve a significant change in volume. Okay, so we have to always try and ventilate our patients in this zone. Okay, so as I told, the goal should be to maintain or to give CPAP or mechanical ventilation in the zone of optimal compliance, so that with minimal pressures we are able to get a better volume. And in both over expanded and under expanded zones, the compliance will be low, the slope of the curve is less, and so the gas exchange will be very poor. So that is why we should avoid both over distension and under expansion. Okay. So coming to the lung volumes and capacities, I'll not go much into the detail. This is all most of physics, but what is of interest to me is the this part, that is the functional capacity. functional residual capacity. Okay, so what is functional residual capacity? It is the volume of air which is left inside the lungs after a normal tidal breathing. Okay, so what all waves you can see here, all these are normal tidal breathing. Okay, so whatever gas is left behind in the lungs at the end of normal tidal breathing is what we call FRC. Okay, and FRC is nothing but a balance between the collapsing pressures and the distending pressure of the lung. Okay, so distending pressure क्या होगा? The chest wall compliance, and the collapsing pressure is nothing but the lung compliance. ठीक है, तो lung compliance and chest wall compliance दोनों एक पॉइंट पे एक दूसरे को नलिफाई करेंगे, एंड द लंग विल बी इन अ व्हाट टू से सेमी ओपन स्टेट. दैट वॉल्यूम जहां पे वो सेमी ओपन है, दैट इज नथिंग बट योर फंक्शनल रेजिडुअल कैपेसिटी. ठीक है. Then coming to the common ventilation terminologies which we often see or often use in our day-to-day practice, one is the tidal volume. So it is nothing but the volume of gas which is moving in and out with each breath. Okay. Second comes the dead space. Dead space is that part of the tidal volume which is not involved in gas exchange. Okay. So if you are breathing air which is say 6 to 8 ml per kg, all that 6 to 8 ml per kg is not being used for gas exchange. Only a part of it is involved in gas exchange. The rest of it stays in the airways and then comes out. Okay. So the part which is not involved in the gas exchange and it is just staying in the airways, that part is the dead space. Okay. Then comes the minute ventilation. Minute ventilation is nothing but the tidal volume into the respiratory rate. So tidal volume into the tidal volume minus the dead space into the respiratory rate. This is what we call alveolar minute ventilation. That is, we are calculating or we are taking into account only that part of the tidal volume which is involved in gas exchange. Okay. Now, the dead space is important as the delivered tidal volume is always, as I told, it is not the volume which is involved in gas exchange. So we need a good flow sensor at the bedside to decide how much is the effective dead space. Okay, and there are certain ways by which we can reduce the dead space. One is to cut the length of the ET tube. Okay, so that is why most of the units, if you go and see, they have a tendency to cut the length of the ET tube to as small as possible, because जितना ज़्यादा ET tube का length होगा, one thing, it increases the airway resistance. ठीक है. How it increases the airway resistance, I will discuss in the subsequent slides. Second, the ET tube में जो length है, that is anyways not going to help in gas exchange. ठीक है. So that is why it is a waste space or a dead space. So that is why we try to cut the length of the ET tube, because one thing is increasing the dead space, and second is it increases the resistance. Okay. And second possible way is you have to increase the diameter of the ET tube as largest as possible. Okay, so as to decrease the peritubal leak. Okay? So that is why I always keep on insisting that use a proper size ET tube, ensure that there is not much of a peritubal leak, so that there is not much of volume being lost in the peritubal area and not involved in gas exchange. Okay. Now, normal tidal volume in a normal newborn, it is 5 to 8 ml per kg, while in this thing preterms, we target around 4 to 6 ml per kg we target around 4 to 6 ml per kg in term units when we are giving positive pressure ventilation, whereas for preterms, we set it around 5 to 8 ml per kg. And it is again expected to change as per the disease states. Okay. So normally the respiratory rate is around 40 to 60, and if we multiply this respiratory rate with the tidal volume, that is 4 into 40 or 60, what we get is minute ventilation of around 200 to 480 ml per kg per minute, right? So this is the normal value of minute ventilation. Coming to the functional residual capacity, I discussed it briefly before also. So it is nothing but the volume of gas that remains in the lungs at the end of normal tidal breathing. And in a normal baby, the value of FRC is somewhere around 30 ml per kg. Okay, so if my baby is having a weight of say 2 kgs, somewhere around it should be 60 ml, right? And in the baby with hyaline membrane disease or RDS of prematurity, the FRC is expected to be low because the lung compliance is very high and the chest wall compliance is the lung compliance is very low and the chest wall compliance is very high. As a result, the lungs are almost collapsed, so the FRC will be very low. Okay. Then coming to the resistance. So resistance is nothing but the opposition to the airflow through the air conducting system. ठीक है, तो air को अगर nose से या वेंटिलेटर से लेके लंग्स तक पहुंचना है, तो it has to pass through many small tubules. So definitely there is going to be some resistance or opposition to the airflow. So to measure, or it is a measure of that opposition which the air has to face when it is passing through all these airways. Okay, so that is what we call resistance. Now this resistance, it can be of two different types. One is the viscous resistance and second is the airway resistance. So airway resistance, as the name suggests, it is because of the airways. जो भी आपका lung tissue है, bronchi, bronchioles, terminal bronchioles, so all these will contribute to the resistance. ठीक है? So that is accounts for around 55%. Whereas there is some resistance which is because what we call a viscous resistance. So viscous resistance क्या होगा कि gas molecules. See, even in the air which is passing from the ET to the lungs, air also has a lot of molecules. So when these molecules they are flowing across one another, there is always friction between the air molecules also. हम जो है बहुत ज्यादा फ्लो में यूज कर रहे हैं, ठीक है, वी आर गिविंग द गैस एट अ फ्लो ऑफ 6 to 8 और समटाइम्स 10 or 12 liters per minute. तो हम उतना ज्यादा जब फ्लो यूज करते हैं तो क्या होता है कि देयर इज फ्रिक्शन बिटवीन द एयर मॉलिक्यूल्स जो पास हो रहे हैं, देयर ऑल्सो विल बी फ्रिक्शन बिटवीन द एयर मॉलिक्यूल्स एंड बिकॉज ऑफ दैट ऑल्सो देयर विल बी सम रेजिस्टेंस. ठीक है, so the resistance is basically of two types. One is the airway or the this thing resistance because of the tissues, and second is the viscous resistance. Okay, and to define it, we can tell it is pressure change in the pressure per unit change in flow. So your compliance was change in the pressure per unit, sorry, change in volume per unit change in pressure, whereas resistance is change in pressure per unit change in flow. So that was volume by pressure compliance, and resistance is pressure upon flow, right? So resistance is nothing but the change in pressure upon V dot. V dot stands for flow, whereas simple V stands for volume, right? So change in pressure divided by the flow, that represents resistance, right? So now again, just to clear one more concept, that if you use adequate flow in a ventilator while you are ventilating a child, if you use adequate flow, suppose I use a flow of 6 to 8 liters per minute. Suppose I use a flow of 6 to 8 liters per minute, what happens is the gas molecules will flow in a laminar fashion. That is, there will be a laminar flow. But जैसे ही आप flow बहुत ज़्यादा बढ़ा दोगे, suppose I intubate a child and keep a flow of 16, 18, रखने को तो मैं उतना भी रख सकता हूँ, but why we don't keep it? Because जैसे ही हम flow बहुत ज़्यादा बढ़ाएंगे, होगा क्या कि all the gas molecules will become turbulent. Okay, so the flow which is laminar now will become a turbulent flow, and once it is a turbulent flow, the resistance will increase. Okay, so that is one concept. Second, whenever there is narrowing of the airway due to some reason, okay, so कई बार if the ET tube is kinked, or because there is some secretions or partial blockage of the endotracheal tube, so all that will increase to the airway resistance. Why? Because of one thing is the diameter of the airway also decreases. जो आपको endotracheal tube है, it is acting as an airway. ठीक है, so the diameter also decreases. Secondly, बियॉन्ड अभी तक जो फ्लो लैमिनार फ्लो था, बियॉन्ड द पॉइंट ऑफ ऑब्स्ट्रक्शन ये फ्लो जो है टर्बुलेंट हो जाएगा, एंड एज सून एज इट बिकम्स टर्बुलेंट द रेजिस्टेंस इंक्रीजेस. ठीक है, so that is why you have to take care that there is no partial block or secretions in the endotracheal tube. Then unit of resistance is centimeters of water per liter per second. Okay, so centimeters of water is for pressure. What I told is resistance is nothing but the change in pressure by flow. Flow is always liters per second. Okay, in our ventilator also, whenever we set flow, it is always in liters per second. So pressure upon flow, that is centimeters of water per liter per second. That is the unit of resistance. It depends. Now the formula for resistance is this one, that is R is equal to 8 eta L upon pi R square. Okay, so this is nothing but the Poiseuille's law, again a law of physics. ओके, सो पोजलीज लॉ में क्या है कि भाई अगर हमको किसी भी ट्यूब से गैस फ्लो कितना है उसका रेजिस्टेंस देखना है, तो दैट रेजिस्टेंस ऑफ द गैस फ्लो थ्रू अ पर्टिकुलर ट्यूब डिपेंड्स अपॉन द लेंथ ऑफ द ट्यूब, एंड इट इज इनवर्सली प्रोपोर्शनल टू द रेडियस ऑफ द ट्यूब. ठीक है, सो जितनी ज्यादा लंबी आपकी एंडोट्रेकियल ट्यूब होगी व्हेन यू आर इंट्यूबेटिंग अ चाइल्ड, जितनी ज्यादा लंबी आपकी एंडोट्रेकियल ट्यूब होगी उतना ही ज्यादा रेजिस्टेंस बढ़ जाएगा, ठीक है। दैट इज व्हाई always it is a practice to cut down the endotracheal tube short, okay, because it decreases the dead space also and it decreases the resistance also, okay. So that is one concept. Second, that is why we always use a larger size ET tube as large as possible. Okay, kai baar, I mean, that is why we don't use a 2.5 ET tube in a child who is having a weight of 3 kg, because क्या होगा कि if you are using a very small endotracheal tube diameter, ठीक है, तो if the diameter is small, the radius will be small. The smaller the radius, the resistance will be very high, okay, because it is inversely proportional to the fourth power of radius. तो अगर आपका resistance जो है, even if it increases by 4, okay, 4 times increase in the resistance, okay, suppose आपकी endotracheal tube जो है उसका साइज आपने काट के 1/4 कर दिया, ओके, और द डायमीटर इफ यू डिक्रीज इट टू 1/4, जो रेजिस्टेंस है इट विल इंक्रीज बाय 16 टाइम्स, ओके, दैट इज 4 to the power of 4. So that is why you have to choose the widest possible endotracheal tube as wide as possible, okay, for the size of the baby, okay. So again, normal values of compliance, I had already told. These are the normal values for resistance. Okay, so in a normal lung, it will be around 20 to 30 centimeters of water per, liter per second. In RDS, otherwise the resistance has to be low. But why it? I mean, resistance should not be affected much. But why in cases with RDS, resistance will increase to some extent is because there is a tendency for the airways to collapse. Okay, so because of the collapse of the airways, क्या होगा कि उनका diameter कम हो जाएगा. Once the diameter decreases, we have seen in the previous formula also, it is inversely proportional to the fourth power of radius. So there is some increase in the resistance. BPD is primarily a disease of airway resistance. So that is why in patients with BPD, your airway resistance will be very high. And similarly in patients with MAS. Okay, so airway, MAS, BPD, both are diseases of resistance primarily, whereas RDS is a disease of lung compliance, right? Then coming to one more important concept is time constant. तो टाइम कांस्टेंट क्या है कि सपोज जैसे मैंने पहले भी बताया कि whenever we are using a mechanical ventilator or whenever even the baby is breathing spontaneously, there is a pressure difference, ठीक है। तो what we are doing is कि pressure difference बना रहे हैं between point A and point B, and then we are allowing the gas to flow from point A to point B. बट नाउ फॉर दिस प्रेशर डिफरेंस जो हमने बनाया है, गैस फ्लो कब तक कंटिन्यू करेगा? पॉइंट ए और पॉइंट बी के बीच में गैस फ्लो जो है कब तक कंटिन्यू करेगा? जब तक दोनों पॉइंट्स का प्रेशर जो है इट बिकम्स इक्वल, तभी ही फ्लो बंद होगा एंड देन एक्सपिरेशन विल स्टार्ट। ओके, सो दिस इज द नॉर्मल फिजियोलॉजी। अब द प्रेशर डिफरेंस जो है उसको इक्विलिब्रिएट होने में, दैट इज पॉइंट ए और पॉइंट बी के बीच में जो प्रेशर डिफरेंस है जिसकी वजह से गैस फ्लो हो रहा है, for that pressure difference to equilibrate, some time will pass. Okay, it is not, it is very fast, but still there is a fraction of a second, ठीक है। ऐसा नहीं है कि सडनली दोनों जगहों का प्रेशर सेम हो जाएगा। इट टेक्स सम टाइम फॉर द गैस टू फ्लो फ्रॉम पॉइंट ए टू पॉइंट बी, एंड देन इवेंचुअली पॉइंट बी का प्रेशर बढ़ेगा, एंड देन देर विल बी अ पॉइंट जब पॉइंट ए और पॉइंट बी का प्रेशर एकदम बराबर होगा, उसके बाद में बी का प्रेशर बढ़ेगा एंड देन गैस विल फ्लो फ्रॉम बी टू ए, ठीक है। सो दैट इज हाउ इंस्पिरेशन एक्सपिरेशन कंटिन्यूज। सो इट टेक्स सम टाइम फॉर द airway pressure and the volume changes to equilibrate throughout the lungs, ठीक है। So that is what we call time constant, ठीक। So basically it is the time taken for the pressure and volume changes to reach the distal airways. अभी अगर हम वेंटिलेटर पे रख रहे हैं बच्चे को, so we are delivering a PIP of say 16, तो वो 16 PIP ET की टिप तक जाएगा। वहां से लेके डिस्टल एयरवेज तक पहुंचने के लिए इट इज गोइंग टू टेक सर्टेन टाइम, दैट इज व्हाट वी कॉल टाइम कांस्टेंट। ओके, टाइम कांस्टेंट इज अगेन नथिंग बट प्रोडक्ट ऑफ कंप्लायंस एंड रेजिस्टेंस, ठीक है। इट इज, आज बहुत सारे फॉर्मूलाज हैं, इट इज मोर ऑफ फिजिक्स बट दीज आर ऑल बेसिक्स ऑफ मैकेनिकल वेंटिलेशन। So time constant is nothing but it is a product of resistance and compliance, and usually it takes 3 to 5 time constants to achieve adequate inspiratory time or expiratory time, okay. I'll clear this more. So keep this in mind that time constant is nothing but resistance into compliance, okay. So जितना shorter TI होगा और the inspiratory time, the हम ventilator पे inspiratory time set करते हैं, right? So inspiratory time आप जितना कम रखोगे, you are giving that much less time for the air to reach to the alveoli. ठीक है, and so there will be less ventilation, less pressure delivery. अगर आप सब वो, if you remember, there is a button for TI in the ventilator, जो normally मैं जाता हूँ जब भी सुबह में, हमेशा 0.5 पे ही फिक्स होता है बाय डिफॉल्ट, ठीक है, बट इट हैज टू चेंज as per the disease for which you are ventilating. So if you are ventilating a child for RDS, it has to be on the lower side. If you are ventilating a child for MAS or BPD, it has to be on the higher side. So, but if you keep it very low, if you keep that TI to zero point 0.2, होगा क्या कि you are not giving time for the air to go from this thing from the ventilator to the distal alveoli. So there will be less ventilation. On the other hand, if you are giving a less TE, that is, if you are not allowing the lungs to, sorry, if you are not allowing the air to go out, if you are giving a lesser TE, less air will be cleared from the airways and there is more of air trapping. Okay, because you are not allowing enough time for the alveoli to open complete or to empty completely. There will be some air trapping in the alveoli. Okay, so this is the formula for time constant. Again, I told compliance into resistance. So compliance is nothing but change in volume by change in pressure, whereas resistance is nothing but change in pressure by flow. So ultimately the time constant unit is seconds. Okay, so we get the value of time constant in seconds. Now this is again a very important concept. So time constant जो है, I told before also, it usually takes 3 to 5 time constants for adequate TI or TE. ठीक है, तो what does it mean? If you see this graph, अगर आपने कुछ भी प्रेशर चेंज किया है, ठीक है, so this is my target pressure change. ठीक है, suppose मेरा target pressure change है 20 centimeters of water. So if I want the pressure change to reach the distal alveoli, initial one time constant में, so this 1 2 3 is nothing but the time constant. So one time constant में the pressure कितना equilibrate होगा, और how much of the 20 centimeters of water जो pressure हमने ventilator से deliver किया है, उसमें से कितना एक time constant में baby तक पहुंचेगा, that is 63%. दो टाइम कांस्टेंट में 86%, and only by the third time constant 95% of that pressure will get delivered to the baby's lungs. ठीक है, इसका मतलब क्या है कि if I set a time const if I set a peak inspiratory pressure of 20, means मेरे को बेबी को 20 सेंटीमीटर्स ऑफ वाटर का प्रेशर डिलीवर करना है. तो अगर मैं एक टाइम कांस्टेंट जितना ही अपना इंस्पिरेटरी टाइम रख रहा हूँ, सपोज इस बेबी का टाइम कांस्टेंट है 0.1 सेकेंड, ठीक है. So if I keep the inspiratory time of 0.1 seconds, होगा क्या कि 20 centimeters of water जो pressure है उसका 63% means somewhere around 13 centimeters of pressure only will be delivered to the baby's lung. If I wait till two time constants will be 0.2 seconds in this scenario, in this example. तो 0.2 seconds तक अगर मैं wait करता हूँ तो 86% of the pressure will be delivered. और अगर मैं 0.3 सेकेंड्स तक वेट करता हूँ तो ही जाके जो 20 सेंटीमीटर्स मेरे को डिलीवर करना था उसका 95% मींस समवेयर अराउंड 19 जितना प्रेशर बेबी के लंग को डिलीवर होगा. ओके, सो दैट इज व्हाई वी दिस थिंग कीप इंस्पिरेटरी टाइम जो हमको बेबी को वेंटिलेट करना है, वो इंस्पिरेटरी टाइम शुड बी समवेयर इक्वल टू 3 to 4 टाइम कॉन्स्टेंट्स ऑफ दैट चाइल्ड. ठीक है. So again expiratory time constant will be more because inspiration जैसे मैंने बताया कि inspiration में air flow जो है it will be wider and inspiration is an active process, तो वहाँ पे airway resistance will be less and the diameter of the airways will be wide, whereas during expiration the airways are narrower and also the flow becomes turbulent from the alveoli. Okay, so that is why expiratory time constant is always higher than the inspiratory time constant. Okay, now this is I think very important. ठीक है, I have discussed or I have told you before the normal values of compliance and resistance. ठीक है, तो अगर हम normal lung की बात करें, compliance is 0.005, resistance is 20. अगर हम इन दोनों को multiply करते हैं, we will get a time constant value which is 0.1 to 0.15 seconds. This value is in seconds. Now, how much I said मेरा expiratory time कितना होना चाहिए? It should be 3 times the time constant. ठीक है, तो हाउ मच मैं वेंटिलेटर पे अगर एक्सपिरेटरी टाइम मुझे सेट करना है तो इट शुड बी 3 times द वैल्यू ऑफ टाइम कांस्टेंट, दैट इज 0.3 से लेके 0.5 जितना मैं सेट करूंगा. right? This is the concept behind why I was talking about time constant. ठीक है? So again, अगर सोचो if a child is having RDS जहाँ पे compliance is very low, resistance is little bit elevated, तो उसका time constant जो है 0.05 हो जाएगा. 0.05 is the time constant, means 3 times the time constant will be 0.15 to 0.25. इतना मुझे वेंटिलेटर पे एक्सपिरेटरी टाइम उसका सेट करना है. Similarly, for BPD, आज सुबह ही I think there was a child who is on ventilator, who is being intubated for BPD. I told that only that if you are intubating a child for BPD, it is mainly a disease of the resistance. ठीक है? तो उस केस में आपका जो टाइम कांस्टेंट है वो बहुत ज्यादा हाई होगा एज कम्पेयर टू अ नॉर्मल लंग. ठीक है? तो नॉर्मल लंग का अगर 0.1 है, बीपीडी का इट विल बी 0.18 या समटाइम्स 0.2 से भी ज्यादा होगा. ठीक है? डिपेंडिंग ऑन हाउ मच इज द रेजिस्टेंस, डिपेंडिंग अपॉन हाउ मच इज द कंप्लायंस, वो वैल्यूज आपको वेंटिलेटर पे से मिल जाएगी. यू कैन कैलकुलेट द टाइम कांस्टेंट. नाउ योर एक्सपिरेटरी टाइम शुड बी 3 times द वैल्यू ऑफ टाइम कांस्टेंट. तो समवेयर इट शुड बी 0.45 टू 0.9. मीन्स आपको एक्सपिरेटरी टाइम बहुत लंबा रखना है. एक्सपिरेटरी टाइम बहुत लंबा रखना है, उसका इनडायरेक्ट मीनिंग क्या है? आपका जो वेंटिलेटर रेट है इट शुड बी लो. ठीक है? सो दैट इज व्हाई मॉर्निंग व्हेन आई केम दैट चाइल्ड वाज being ventilated at 40, I asked them to decrease it to 30, because the lower respiratory rate you keep, the more time you are allowing for the gas to go out from the um, um, lungs to the airways. Okay, lungs to the atmosphere. Okay, because BPD is a disease of the resistance, as I said. तो रेजिस्टेंस बहुत ज्यादा है, सो एक्सपिरेशन में बहुत ज्यादा डिफिकल्टी होगी इन बेबीज को. सो यू अलाउ अ लॉन्गर टाइम फॉर देम टू ब्रीथ आउट. Okay, and same was with MAS. ठीक है? So this is the concept of how you set the respiratory rate. If at all your child is not breathing on his own, if he is breathing on its own, then maybe you have to support the breathing, and at the same time, अगर बहुत ज्यादा asynchrony है, then you can consider sedation, right? Then coming to the last part of the talk, that is the variables determining oxygenation. So there are variables which are determining both oxygenation and ventilation. So हम किसी बच्चे को mechanical ventilator पे रख रहे हैं, so we are interested in both things. We are interested in increasing the oxygenation, and also we are interested in in improving the ventilation. Okay, both are separate. Oxygenation means क्या कि blood में oxygen level बढ़ाना. Ventilation means क्या? Gas exchange बढ़ाना. Okay, so ventilator does both the functions. Okay, so if I want to improve the oxygenation, I have to deal primarily with two factors. That is, one, I can increase the mean airway pressure. Second is I can increase the FiO2. To increase the mean airway pressure, to increase the mean airway pressure, this is the formula, that is peak inspiratory pressure into the inspiratory time, and peak expiratory pressure into the expiratory time upon sum of Ti and Te. Okay, so what does it mean? That if I want to increase the mean airway pressure, ठीक है? So this is the pressure volume curve जो हम ventilator पे देखते हैं. Okay, this is the pressure against time scalar, not a pressure volume curve. This is a pressure against time scalar. ठीक है? तो अगर मुझे इसका mean airway pressure बढ़ाना है, so there are I can use either of the four ways. ठीक है? That is, one is to increase the flow. अगर मैं flow बढ़ाऊंगा तो ये जो slant है वो straight हो जाएगा. ठीक है? So that is one way. Second is to increase the PIP. So if I increase the peak inspiratory pressure, ultimately the area under the this thing graph will increase and mean airway pressure will increase. Third is to increase the PWP. Okay, so if I increase the PWP, जो इसमें fourth से represent किया है, if I increase the PWP, the area under the curve will increase. And last is to increase the I is to E ratio. That is, you allow more time for inspiration. So this graph will here increase here. Okay, so of all these options, ठीक है? अगर कोई भी बच्चा desat हो रहा है, if you are not able to achieve good oxygenation while the child is on ventilator, always remember two things: either you have to increase MAP or you have to increase FiO2. If you feel the FiO2 is okay, or you have already kept on 100%, or this thing, then the only way out is you have to increase the mean airway pressure. To increase the mean airway pressure, either you have to increase the flow, or you can increase the PIP, you can increase PWP, or you can increase the inspiratory time. But practically, what we rely more often is either we increase the PWP, which is the most effective way to increase the mean airway pressure, or if you feel your PWP is already high, next what you can increase is PIP. Okay, very often we don't meddle with the flow and the inspiratory time, because those if you increase the flow or the inspiratory time, there can be other problems. That is, if you increase the flow, it may change to a turbulent flow. From laminar flow to turbulent flow, again it will increase the resistance and all other issues may come. So that is why most of the times we try to increase either the PWP or the PIP. Okay, then coming to the variables which are determining the ventilation. So ventilation is actually nothing but CO2 elimination. Okay, so again, it depends upon minute ventilation, and minute ventilation, as I told before, it is nothing but tidal volume into respiratory rate, and tidal volume depends upon the change in the pressure. Delta P is nothing but the change in pressure. That is, if you're intubating and ventilating a child, delta P is nothing but the difference between PIP and PWP. ठीक है, तो अगर मेरा PIP is 16 and PWP is 5, my delta P will be 11. Okay, and so tidal volume depends on two things, that is the delta P and the lung compliance, right? So I think with this I'll end the talk for today. It was more of physics and basics. Next class I'll try to focus more on the disease specific ventilation strategies and various modes of ventilation. If there are any questions, I'll be happy to take.
Thank you so much, Dr. Sandeep. You have simplified the topic. It is really a tough topic for our resident also. So if they are having any query, they can ask. Otherwise, they can put into chat box also. Anyone is having any query about this topic? I think all the concepts are clear. No one is having any query. So thank you, Sandeep. We can stop now. Thank you so much.
Okay, thank you, ma'am.